Mechanical ventilation is a life-saving intervention, but while advances in technologies have increased the safety and performance of ventilators, mechanical ventilation is not without risk. Thus, great efforts should be made to liberate patients from the ventilator as soon as safe and practical. Prolonged mechanical ventilation can lead to poor patient outcomes, including increased risk of developing hospital-acquired infections, such as ventilator-associated pneumonia and other ventilator-acquired conditions, impaired pulmonary function and quality of life, and even mortality. Mechanical ventilation provides breathing support until the lung function is restored. It delivers warm, body temperature 37 degrees, 100% humidified oxygen at FiO2 levels of 21 to 100%. Mechanical ventilation can be delivered by an endotracheal tube, which is what we see in this diagram. Also, it can be delivered by a tracheostomy tube. And finally, there is a third means of delivering mechanical ventilation, and it is through a nasal or face mask. And these are non-invasive modes of mechanically ventilating patients. Specifically, we're referring here to CPAP and BiPAP. Okay. Mechanical ventilators have been designed to provide those functions of warming the air and oxygenating the air. Typically, our upper airway performs those functions for us. But since we bypass the upper airway when we insert an ET tube or a tracheostomy tube, those functions need to be provided by the mechanical ventilator. Okay. Now, I like this picture because we see the nurse who is doing a thorough respiratory assessment, and she's going to be auscultating on both sides. We want to make sure that air is ventilating both sides of our lungs, okay, equally, that we don't have air being delivered only to one side or much more to one side than the other. It's always important, especially after intubation, that the nurse's role is to assess for breath sounds on both sides. If you would only hear breath sounds on one side, that would indicate perhaps bad positioning of the ET tube. Okay, that's really a concern with ET tubes. When an individual has recently been intubated, we want to make sure that that air is being delivered equally to both lungs. Now, let's talk about which patient populations would be good candidates for mechanical ventilation. Patients who have hypoxemia, and we already talked about the definition of that, a PaO2 of less than 80 would be the definition for hypoxemia. Any patient that is hypoventilating, we know our normal respiratory rate is 12 to 20. An individual who is breathing 6 times per minute is hypoventilating, okay? And when you hypoventilate, of course, you're going to retain CO2 so that you will be in a respiratory acidosis. Now, what conditions lead to hypoxemia and hypoventilation with respiratory acidosis? Many, and they're all listed here. Certainly, any individual who has airway trauma needs to have an airway established for them, and that ET tube provides that. We also, for our patients who have exacerbations of COPD, this is like a crisis basically with their COPD. We will need to intubate these patients until we can address it and treat the underlying cause. Perhaps it was a lung infection that exacerbated their COPD. So we will support their ventilatory efforts with the mechanical ventilator until we can address the underlying cause and get them back up to their normal level of functioning. We also use it. Now remember, that brings up a good point here between the exacerbation of COPD and the next illness called acute pulmonary edema. Well, in both of these cases, and even I'm going through asthma attack as well, those conditions show us that mechanical ventilation can be used as a temporary support. Okay, it means that if a patient goes on to mechanical ventilation, our goal is to get them off of it as well. Okay, they don't need to be on it permanently, although sometimes there are patient conditions in which the individual will remain on ventilation for the remainder of their life. Certainly there are those cases, but our goal would be to get them off as soon as possible. Now we also have head injuries, stroke, and comas, and other neurological disorders. Because, and we've talked about this, when there's injury to the brain and increases in intracranial pressure, this can affect the brain stem, and the brain stem is and regulates our vital signs. Again, our heart rate, our blood pressure, our respiratory rate, and our respiratory pattern. So sometimes we have to, you don't have to have a pulmonary disorder to be on a mechanical ventilator. Now, there are many other things that can lead a patient to needing, having the indication for mechanical ventilation. And right there, I want to also just mention drug overdoses. We see patients come in through the emergency room, and they've had, they're basically almost in a comatose state because of a drug overdose. And they're only breathing, as my example is, 6 times per minute. That is not adequate. So they have to be put on mechanical ventilation. Again, hopefully that would be a temporary use of it. And once we get the antidote or it gets out of their system, then they can be weaned off of the ventilator. And the same thing with pulmonary edema. Not all patients with flash pulmonary edema or an exacerbation where you have the buildup of fluid in the lungs, not all of them will need to be intubated, but sometimes they will. So they'll be intubated until we can get the fluid out of their lungs. And we address that with Lasix and also with medications that improve the functioning of the heart itself. Finally, we have on this list obstructive sleep apnea, and this is the indication for a CPAP, a non-invasive form of mechanical ventilation. Now, we've made a lot of advances, as we said, in technologies, and the ventilator, as you see in this picture, is getting smaller and smaller. They used to be pretty awkward, clumsy, big pieces of machinery, but they keep getting smaller. And you see the blue tubing here that leads to the connector piece and connects to the patient's ET tube or trach tube. So the indications for mechanical ventilation are when a patient has undergone general anesthesia or when they've undergone heavy sedation. Also, mechanical ventilators will provide respiratory support following a surgery. So even though the surgery is over, the patient may continue to be on the mechanical ventilator because it helps to decrease the respiratory workload for that patient. Remember, breathing requires work, even though we may not be conscious of it if we have normal respiratory system. But indeed, the work of breathing really exists. And if we want the patient to conserve their energy and and decrease oxygen consumption, then we can continue to keep them on the ventilator, okay, until the patient has healed, and we've allowed the patient time to heal. As we said in the last PowerPoint on ARDS, the hallmark of acute respiratory distress syndrome is refractory hypoxemia. And as we explained, this is characteristic and is the hallmark finding for patients who have ARDS. Hypoxemia that does not improve with oxygen administration. Often it is necessary to add PEEP to mechanical ventilation settings to maintain blood and tissue oxygenation. PEEP decreases cardiac output due to increased intrathoracic pressures. Ventilators that we use these days are called positive pressure ventilators. And that means that they deliver they deliver air to the lungs under pressure. Decades ago, they used to use negative pressure ventilators, and some of you may have heard of the term iron lung. Patients used to be placed in the iron lung, and it was in that environment that they, under negative pressure, that air flowed into their lungs. So, and that is what normally occurs. Normally air moves into our lungs because of the negative pressures there, okay? So it is just the opposite of that when a patient is put on a positive pressure ventilator. Now we have air being pushed into the lungs, okay? And it's pushed in throughout inspiration and expiration. And this keeps the alveoli open during inspiration, and it prevents the alveoli from collapsing during expiration. While it may not seem natural to have air forced into your lungs under positive pressure, there are several benefits. One benefit of positive pressure is that it forces lung expansion. It improves gas exchange, and it also decreases the work of breathing. The patient then can use their energy that they have for the healing process. There are ventilator alarms, and they are used to signal that the client is not receiving the correct ventilation. As you know, airway is the highest priority we have in nursing. So we do not want the patient to lose their airway, and that is a risk associated with mechanical ventilation. So we'll need alarms in place that will notify the nurse that something is not, the patient is not receiving the correct ventilation. Another important point to make is that ventilator alarms should never be turned off. Okay, never. This has been shown time and time again that when alarms are silenced, that is when emergencies occur. The nurse is not alerted to the fact that the patient is experiencing distress. So never turn off the alarms. If the nurse cannot determine the cause of a ventilator dysfunction, the client is disconnected from the ventilator, and you can manually ventilate him with the Ambu bag. So you simply remove the connecting tubing if there is a problem with the ventilator and you cannot fix it, and attach the Ambu bag and manually ventilate the patient. There are 3 types of ventilator alarms: volume, pressure, and apnea alarms. So we get a low pressure alarm when the tubing is disconnected. Okay, so there's a disconnection somewhere in the vent circuitry, in the airflow. Okay, somewhere where the air is being delivered to the patient, and there is a problem somewhere in that connection. So you are not delivering the correct volume that will be ordered by the physician and which will be set on the ventilator by the respiratory therapist. Another low pressure alarm will go off when there is a cuff leak. So you might ask, well, what is a cuff leak? Look at the ET tube in the diagram. There is a small bluish pilot balloon, and we can attach a syringe and inject air into the pilot balloon, and it will inflate the cuff, which is toward the distal end of the tube. That cuff then is going to, when inflated, is going to be touching the walls of the trachea. This is important so that when air is delivered, follow the ET tube from the top to the bottom, to the lungs. You'll see that air that is now leaving the lungs cannot flow backwards around the tubing and up the trachea and escape. That would not be very efficient. We want to deliver a certain volume, a set volume. We don't want it escaping around the ET tube and leaving through the mouth or nose. Okay, so we inflate that cuff to make sure that air does not leak out, that air is only delivered in through one way and leaves through one way, so we can monitor volumes. When there is a leak in that cuff, then we're going to have air escaping. It escapes around the ET tube. Another low pressure alarm will sound when there is displacement of the ET tube, because that indicates that we have lost the airway. Sometimes the ET tube might get pulled out too far, and then we'll need an X-ray, and we may have to reposition it. Other times it gets pushed down too far into the trachea and ends up going into one of the bronchi. And if that's the case, after X-ray, we can reposition it by pulling back on the ET tube. It's very important that the ET tube sits right above the bifurcation of the trachea, because those bronchi, we don't want air delivered to only one side of the lungs. Okay. And typically, when the ET tube is inserted, it will want to slide down into the right bronchus, because the right bronchus is wider and at less of an angle. So it's really easy for the person putting in the ET tube for it just to slide down onto the right side, and then the whole left side, the left lobes are not being ventilated. So we need to pull it back so that the air is delivered to both lungs. Okay. This diagram shows you the endotracheal cuff in blue or aqua color here. And all the pink, that's the ET tube, and that's where we find the flow of air into and out of the trachea. Okay. So we inflate the cuff so that air is only delivered into the lungs and out in one direction. Okay. That is the sole purpose of the cuff. It's all about making sure that the air and the gases that we want to deliver to the patient's lungs go in that direction. Okay, that is the sole purpose. I've seen questions like that in nursing. So make sure you understand what the purpose of that cuff is. The inflated portion forms a seal against the tracheal wall. This seal prevents gases from leaking past the cuff, and it allows us to deliver ventilation under positive pressure. Now, a nice aside, which students like to pick this answer, they like to say, oh, that seal is there to make sure that gastric contents don't go into the trachea. Well, that happens to be an advantage that comes with a cuff. It also prevents matter from the stomach contents from going up the trachea and back down into the lungs. Okay, so that's good, because when people are laying down and they're intubated, remember they are at risk of aspiration. It's noxious aspiration, meaning stomach contents can go up their esophagus and then go back down into their trachea. It's not going to get very far so long as we don't have a leak in our cuff. If the cuff is inflated, it will prevent aspiration as well, but that is not the purpose of the cuff. Okay. All right, so remember, to prevent or at least decrease the risk of aspiration, keep the head of the bed of your patient elevated 30 degrees at all times. And if your patient is receiving enteral feedings, you'll need to check residuals every 4 hours to decrease the risk of aspiration. Because if they're having too much residual in their stomach, they're going to be at increased risk of that stomach contents getting into the lungs. Okay, and that will lead to pneumonia and all kinds of problems. So again, we have to think about those things with our patients who are intubated. All right, after intubation, after a patient has been intubated, the cuff is inflated with air. Okay, and as we said, this is done by attaching a syringe to the pilot balloon, that little blue balloon. The pilot balloon is connected to the cuff by a thin blue tube there. As the syringe supplies pressurized air, the pilot balloon and the cuff inflate. Once the cuff is inflated, the syringe is removed. Air does not leak out as there is a one-way valve at the pilot balloon. By putting the little pilot balloon between your fingers, the nurse can estimate the amount of pressure in the cuff. So if the pilot balloon is really blown up full and it's really taut, then that means that your cuff balloon is also inflated in a full manner. If the cuff is leaking due to damage, the pilot balloon is going to collapse. Now, it's also important because when you have this balloon inside the trachea, pushing on it, causing pressure, this can lead to tracheal erosion by the cuff, We want to prevent a pressure ulcer forming inside the trachea. We'd like to make sure that the cuff pressure is less than 20 millimeters of mercury. And we do measure cuff pressure every 8 hours. Okay, that's for the patient's safety. And actually, there is a technique that ICU nurses will use, and it's called the minimal air leak technique. And that assures us that we don't have too much pressure in the cuff, but we don't have a large leak where ventilated air can escape. So there is a technique where nurses will auscultate to hear just a tiny little leak in the cuff that makes sure that we are not exerting too much pressure inside the trachea. Now, there is also a risk of mucosal erosion. In other words, we can cause pressure ulcers to form in the mouth, oral or nasal tracheal tube pressure ulcers. That's why when you have an oral ET tube, it's important to change the position to the other side of the mouth every 24 hours. And it's also important to support the tubing with these black brackets that you see here. They are supporting the tubing so it's not hanging down and increasing the pressure and supporting mucosal erosion. So we use the support tubing to prevent weight of the tubing or pulling on the tube. I also like this picture because you can, well, for many reasons. Certainly the airway is secured usually with tape or ties. As we see in this picture, we have ties. But also you can see that there are black numbers printed along the ET tube. And we use the number for each individual patient to indicate to us the proper positioning of that ET tube for that patient. For example, it may be at 24 centimeters at the lip line, and you would document that. That way, even if the patient is turned from one side to the other, or the sheets are changed and he's turned back and forth, we can always just glance at the lip line and see if it has moved at all. Because if it has moved, then we have to adjust it. So we always want to be very careful that we don't have the ET tube become dislodged. Okay, so there's a picture of those numbers. So this slide provides a closer look at the ET tube and those markings on it. We like to document where they are in the patient's lip line so we know that the position of the ET tube, the patient's airway and way of receiving oxygen is it has not been lost. Okay. Now this slide would like to talk about high pressure alarms on our ventilators. There are certain things that cause the ventilator to alarm, and they're related to high pressure. Some of these things are listed here, such as excess secretions. Well, when we intubate a patient and we suction them, every time we introduce that catheter, we are going to stimulate the patient to make secretions. Okay, so when we typically will follow the rules to suction only every 2 hours or as needed. Sometimes a patient needs it more than every 2 hours, but we have to understand that every time we go down with the catheter, we're stimulating the patient to actually make more secretions. So we should only suction when needed, or usually no more frequently than every 2 hours. When excess secretions build up, we're going to get high pressure alarms because it's very hard for the machine to push volume in when there's lots of secretions. Okay. Another thing that will cause the high pressure alarm is a patient who's biting on the tubing. And we do have things called bite blocks now, and so we can use the bite block if needed, if the patient continues to bite on the tubing and we continue to get high pressure alarms. So we can use the bite block to help avoid that. Also, any kinks in the tubing will give a high pressure alarm, and client coughing, that can be an issue, and we like to address the reason for the coughing to eliminate the coughing. Sometimes the coughing is because they need to have secretions removed. So suctioning becomes a very big part of the nurse's role when our patients are intubated. Other things can also cause high pressure alarms, certainly when our lungs are full of fluid, like a pulmonary edema, because we can't get the set volume into the lungs because of all the fluid, so that becomes a high pressure alarm. And there are other things you see listed there as well. Oh, by the way, I forget to mention that you will have questions. You'll have at least 2 questions regarding what causes a low pressure alarm and what causes a high pressure alarm with mechanical ventilation. Okay, now here's an up-close look at the catheter mount. The catheter mount is that green plastic elbow joint type of device, and it allows us to connect the ET tube down at the bottom with the tubing to the machine. Okay, so that's the catheter mount. When we speak about that, that's what we're talking about. Remember, ET tubes come in different sizes. Okay, that's important to know. Not one size fits all. We all have different size tracheas, different size bodies, and so we would need the one that provides the best airway for the patient's size. We have pediatric ET tubes, we have large ET tubes. But if the ET tube is too small for the person, it's basically going to be like trying to breathe through a straw. So that's not good. We wouldn't want to do that. So the ET tubes are often connected to the breathing system with a catheter mount, and it provides a more flexible connection. The catheter mount is then connected to the breathing system. Now, of course, we hope that during these emergency situations and we need to intubate the patient and connect them to a mechanical ventilator, we certainly hope that we can get them off as soon as possible. If it develops that they cannot be getting off of the ventilator anytime soon, or the physician expects that it's going to be a prolonged course, then they may want to go ahead and put in a tracheostomy. So they can perform a trach and remove the ET tube. There are benefits if you need to be on prolonged mechanical ventilation to having a trach instead of an ET tube. It's much easier. Nursing care is easier, especially with respect to suctioning, and probably some of you have already had that experience of being able to suction a trach. And so that's a lot easier than suctioning an ET tube. Also, there's decreased airway resistance with a trach, and therefore there's decreased work of breathing, and this may promote early extubation or getting off of the mechanical ventilator. Okay. The trach is a more secure airway. Okay, it's not as likely to be dislodged as an ET tube. It also allows the patient to speak and improves the patient's comfort. It allows the patient to eat. So improvement in the patient's psychological state results because now they can eat and speak. Also with a trach, it does prevent laryngeal injury. When we insert an ET tube, there is a risk that we cause laryngeal injury. We have to pass the tube through the voice box and the vocal cords. So we can definitely cause injury with an ET tube, and we avoid all of that when we use a trach. It really comes down to this question for the healthcare provider. Fortunately, nurses don't have to make this decision, but we have to understand their thinking behind it. The question is to trach or not to trach. The patient has an ET tube, they're being mechanically ventilated. Has it come time to switch him to a trach? So if the patient has a prolonged need for an artificial airway, then insertion of a trach is the preferred approach for all of the reasons we just mentioned. The difficult issue is how long is long, and when is the tracheostomy, when should it be performed? If it's anticipated that the artificial airway will be needed for less than 10 days, then an ET tube is preferred. But if it's expected that the patient will require an airway for greater than 21 days, then a trach is preferred. But these are not hard and set rules. These are just some generalizations that can be used to guide these decisions. In many patients, it's difficult to predict how long they will require the artificial airway. And so in these cases, the patient should be reassessed on a daily basis to determine whether the trach is required. The decision to proceed with a trach should be made as early as possible in the patient's course so as to minimize the length of time with the ET tube. Once the decision to proceed with a trach is made, it should be performed expeditiously right away, unless there are specific contraindications. Certainly, if the patient is hemodynamically unstable, we are not going to have them undergo this procedure or surgery. So there are other reasons in which there could be contraindications. For example, if the patient has a history of a coagulopathy, in other words, he doesn't clot, he bleeds for long periods of time, then certainly that would not be a good indication to go ahead and proceed with the trach. Okay. We're going to talk about two different modes of ventilation that are very commonly used in the ICU. The first of these will be assist control. Assist control, or AC ventilation, is the simplest and most effective means of providing full mechanical ventilation. In this mode, each inspiratory effort beyond the set sensitivity threshold triggers delivery of the fixed tidal volume. If the patient does not trigger the ventilator frequently enough, the ventilator initiates a breath. This ensures the desired minimum respiratory rate. Okay, so let me tell you this once again. With assist control, patient effort above the set rate triggers delivery of the fixed tidal volume. With assist control, as it says on this slide, there is a preset rate and a preset tidal volume. Okay. An average tidal volume for an average adult would be about 500 milliliters. Okay. However, if you have a very large patient, then it may be set at 700. The orders will come from the physician. In addition to setting the ventilator with the proper tidal volume, the respiratory therapist also sets the ventilator rate. In other words, how many breaths per minute. This also will be part of your order. So you'll have a rate, say, of 12 and a tidal volume of 500. Now, you will receive the order, but the nurse never touches the ventilator. Okay? all settings on the ventilator are done by the respiratory department. Okay? We do not do that. Of course, we need to handle alarms that go off and assess the patient and fix many things. If there's a disconnection, of course, you would reconnect it. But we do not take the physician order and change the knobs and settings on the ventilator. That is not our job, okay? But it is our job to notify respiratory when we have a problem with the ventilator, or if there has been a change in the settings, okay? Frequently, a physician would come by, he makes a change to the settings. I call respiratory and say, just received orders to change the vent settings. They'll say, okay, I'll be right up, and we do that. It is your responsibility to make sure that the orders match the settings, okay? In fact, that's the first thing I do when I receive a patient in report that's on a ventilator. I want to make sure that all circuits are intact and the ventilator is functioning properly, and I document the rate and the volume to indicate that they do match the physician orders. Okay, so with assist control, the patient is not allowed to take their own breaths. If the patient even begins to take a breath on his own, that little beginning part, that's it. The ventilator takes over and pushes in the set volume of 500, say, into the patient. The patient is not going to be allowed to take his own breaths. Okay? Usually, when my patients are on assist control, I realize that they are getting the maximum assistance, and they're really probably not in a very good medical condition. They're probably going to be worse off than patients that are on the next mode that we talk about. Okay. So there is a set rate and there is a set volume with assist control. And every time the patient begins or thinks he wants to take a breath, the machine takes over and delivers the breath. Now, the next mode that we'll talk about is SIMV, which stands for Synchronized Intermittent Mandatory Ventilation. SIMV, just like AC, also delivers breaths at a set rate and volume that is synchronized to the patient's efforts. What's different when you compare it to AC, however, is that with SIMV, the patient efforts that are above the set rate are unassisted. Okay, so what that means is, yes, they're going to get the 12 breaths with 500 mLs if that's what it's set at. But if the patient decides to initiate a breath on their own, go right ahead. Do what you can do. Can you take a breath of 200 cc's? Okay, good for you. And the machine allows the patient to do that. This mode is popular. Despite the fact that it does not provide full ventilator support, as does assist control. So again, let's review what's on this slide here. The other common form or mode of ventilation is SIMV. Now this is selected on the screen of the ventilator, so the mode is up there for you. You can check that when you come into your patient's room to know what mode they're on. Are they on assist control or are they on SIMV? It will be on the screen. Again, both of these modes have a preset rate and tidal volume. That's going to be in your physician order, and that's going to be set. The machine will be set to deliver that. However, when it has SIMV as the selected mode, the patient is allowed to initiate their own breaths, even if they can't make 500 cc's, for example. If they make 100 this time, oh well. If they make 300 next time, oh well. You see, what I like about this and why I think that the patient is not in as serious a condition is because they're able to use their muscles of respiration. Okay? In assist control, they are not allowed to use their muscles of respiration. And so you know what happens in assist control. What happens when you don't use your muscles of respiration? They're going to become weak. And truthfully, it's going to be really harder to get you off of the ventilator. But on SIMV, it lets the patient, if they're capable or wanting to take a breath on their own, to do it. So they do still get to use their muscles of respiration if they want to. This increases the work of breathing, and it can lead to muscle fatigue in these patients on SIMV. Okay. I also have included in your module a nice guide to ventilators, and that will be very helpful as well in supplementing the content that we are covering here. Now let's try this question. Which of the following modes of ventilation can increase conditioning of the respiratory muscles? And the answer is all of them except assist control. In assist control mode, the ventilator takes over the work of breathing. Any breaths initiated by the client are augmented by the ventilator at full tidal volume. In other modes, the client must generate the force to take a spontaneous breath or spontaneous breaths. Okay, so all of those modes listed there can increase conditioning or strengthening of the respiratory muscles, but not assist control. Keeping alveoli open between breaths improves ventilation perfusion relationships and diffusion across the alveolar capillary membrane. This reduces hypoxemia and allows use of lower percentages of inspired oxygen. The mode of PEEP is particularly useful in treating patients with ARDS. PEEP stands for positive end expiratory pressure. This mode is going to be selected on the ventilator screen. You will see that it is set, and it is positive pressure. It is maintained in the airways during exhalation and also between breaths. Keeping the alveoli open between breaths is very beneficial to ventilation and perfusion. PEEP prevents atelectasis from occurring. Typically, they will set PEEP at a 5 or 10. It's just a very small amount of pressure, just a little bit at the end of expiration. So at the very end of an exhale, There'll be a little puff of air, just a little bit, to maintain the alveoli open and improve gas exchange. Now this, I think, is a little bit of a tricky question, especially since I haven't told you this. But let's see how it goes with what you know so far. A patient with ARDS who is receiving mechanical ventilation using SIMV has settings of fraction of inspired oxygen and FiO2 of 80%. Tidal volume is 500. The respiratory rate is 18, and it's a PEEP of 5 centimeters. Which assessment finding is most important for the nurse to report to the healthcare provider? So when you have these type of questions that ask you what you need to report to the healthcare provider, you're looking for something that is not expected, something that indicates that there is a complication, something unexpected has occurred or is occurring. Do not pick something that is expected. So you might try that technique and see what answer you come up with. By the simple process of elimination, you should be able to get rid of A, B, and C. All of those things could be quite characteristic of a patient who has ARDS. There would be no reason to call the doctor and tell your patient your patient has symptoms of ARDS, because he knows he has ARDS. That's why he's ventilated, and that's why he's receiving PEEP. Okay? But what it's got to get our attention or alert us is the oxygen saturation of 99%. Okay, that is way too high. And so I want to tell you that there is this standard rule, and I wish I had mentioned it earlier, but whenever you've heard that oxygen is a drug, and we do not want to expose patients to prolonged periods of receiving oxygen. Okay, we always want to deliver the lowest concentration for the shortest period of time. Okay, that is the goal when it comes to oxygen, because high concentrations of oxygen for prolonged periods of time lead to oxygen toxicity. And that is a very serious problem. And the fact that this person's FiO2 is 80%, that's a high concentration of oxygen. And now I see that the oxygen saturation is 99%. That indicates to me that this oxygen concentration is too high for the patient, and he's at risk of becoming toxic. So remember that rule, the lowest concentration possible for the shortest period of time. What they discovered decades ago, when they had premature babies, they would put them in oxygen tents, 100% oxygen tents. And do you know what happened to those little preemies? They're still alive today. They're out there. They're in society and functioning, but they're blind. Yes, 100% oxygen for prolonged periods of time can lead to blindness, and it has. And that's what we learned from that oxygen can cause a lot of damage, and so we don't want to overexpose our patients to oxygen. Okay, now let's go on and talk about the weaning process. We want to get the patient off of mechanical ventilation if at all possible. And before we extubate them and take the tube out, for example, We want to see if they are going to be able to tolerate breathing and the work of breathing on their own. And we do that by making changes to the mechanical ventilator. The changes will allow the patient to have longer periods of breathing on their own, or longer periods of spontaneous breathing. And so then the patient is using their respiratory muscles and hopefully increasing the strength of their respiratory muscles. Okay. We also use pressure support to help the patient during this time to augment inspiration and increase the patient's endurance to see how long they can last like this. The nurse has an important role to monitor the patient throughout the weaning process to see if the patient can tolerate these changes. If you see that the patient is struggling, that the work of breathing is too much for them and is fatiguing them, then that is needs to be addressed, and the physician should be notified. And he will. I mean, the physicians, of course, make their rounds, and so they will explain that the patient is fatigued during the period where he's on his own and breathing. And we can monitor that in terms, are they diaphoretic? Are they breathing, rapidly, and they're struggling with their breaths? We can observe that. So frequently the patient will be extubated if they can sustain 1 hour of breathing on their own. Okay? That's when they can breathe on their own for 1 hour, then it's a good indication that they might be ready to have the tube removed or be extubated. Extubation means everybody's in the room with the patient. And this picture is not truly that accurate because, of course, during extubation, this patient would be sitting up to maximize his lung expansion. Okay, during extubation, the patient is sitting upright. We want to suction the oral cavity, make sure that he doesn't take his first breath and inhale a bunch of saliva and choke on it. We want to do everything we can to promote a successful extubation. The nurse is in the room, the physician is in the room, and the respiratory therapist is in the room. Okay, so the extubation takes place, and if all seems well, the physician and respiratory therapist leave the room, and then it's the nurse who has to assess the patient and make sure that they are tolerating the extubation. Okay. Certainly we wouldn't want to extubate a sedated patient, somebody who's still groggy. That wouldn't be like setting them up for success at all. So these are things that we have to think about. All right, so to make sure we have a successful extubation, the nurse will suction the oropharynx and trachea prior to the extubation. We will monitor, the nurses will be monitoring to make sure that the weaning process has gone smoothly. The patient did not tolerate the weaning if their respiratory rate is over 30. In my book, that's a red flag, and it should be for you when you're answering nursing questions. If a person has a respiratory rate over 30, they are in distress. Okay? They are not tolerating it. If their oxygenation level falls below 90%, another red flag. If you notice any use of accessory muscles or diaphoresis, they are having a hard time breathing. And most definitely, if they demonstrate stridor, then that means they're not tolerating the weaning. Same with bronchospasm. And the other more subtle thing that you need to look for are changes in level of consciousness. We already said that if oxygenation is impaired, then the brain doesn't receive enough oxygen and they have changes in level of consciousness beginning with restlessness. Okay, so any change like that would indicate that they're not ready to be weaned, or if they have been extubated, then that might mean that they need to be re-intubated. So certainly you would have to be in contact with the physician to notify him that the patient is not tolerating the extubation, and then he could make the decision to re-intubate if necessary. Another concern for the nurse is to make sure that the patient does not extubate himself accidentally. Okay, we don't really need to get too carried away with it, but you understand if they take that ET tube out when they are not ready, they have lost their airway. Okay, so we have to monitor the patient closely. At times, we even have to use bilateral soft wrist restraints to make sure that the patient doesn't pull it out. This whole thing, being intubated, is very uncomfortable. I have not been intubated personally, but I have gone to a simulation exercise for critical care and had a ventilator mouthpiece put in my mouth so I could feel the different modes and the positive pressure of air going into my lungs. And I can tell you, does not feel natural at all. It's just the opposite. And they're pushing this air into your lungs. And I'm sure that beyond being uncomfortable, that they may be in pain as well, depending on their health condition. So they're not welcoming this tube down their trachea. And sometimes they might want to pull it out. Sometimes you might even have to chemically or medically sedate the patient if they are agitated and if they are confused or wanting to pull out their ET tube. Okay. Oh, good. I wanted to talk about this next because you will have a test question on this as well. Just remember, we never sedate patients without giving them pain medication as well. Our mechanically ventilated patients, especially in the ICU, are almost all going to be sedated. When they are sedated, they use medicines that are listed here. The most common one is Diprivan or Propofol. It's the same medication. It's a white solution. And you'll see that this is hanging at the bedside of most intubated patients for sedation purposes. Okay, they could use other drugs such as Valium, Ativan, or Versed. But the concept they're going to test you on is that if you sedate a patient, you must provide them with an analgesic such as morphine or fentanyl. Okay? We're not going to sedate someone and not even be able to ask them if they're in pain. That would be cruel. So we go ahead and administer these two drugs together, basically. And that's what they're going to test you on. I don't care what other medications they list in a multiple choice question. You have got to have listed for the mechanically ventilated patient, you must select one sedative and one analgesic. Okay? Excessively sedated patients are not candidates for spontaneous breathing modes on the mechanical ventilator. Excessively sedated patients that are not candidates for breathing modes that require patient respiratory effort. So spontaneous breathing modes are good because they help the patient maintain their muscle strength, the respiratory muscle strength, and also prevent atrophy of those muscles. but we certainly cannot choose one of those modes for somebody who is excessively sedated. So let me ask you this. How are you going to do a neuro assessment on your patient who is mechanically ventilated and on a sedative? Say your patient came in with a head injury and he needed to be intubated, and now he's on sedatives because it is so uncomfortable being intubated. How are you going to assess this patient? Well, the answer is that you have to adjust the drip rate of the Diprivan. You need to titrate it. So if you decrease the dosage with the roller clamp, the patient will wake up, so to speak. He will become alert. If you decrease it enough, he will come to, and at that point you can ask them questions. You can ask them so that you can make your neuro assessment. But then when you have completed your neuro assessment, and this doesn't take long, then you go back and slowly increase the dosage until he goes to sleep again. And that's how we do it. Okay? Now, other medications that mechanically ventilated patients may be taking or we may use as nurses with these patients, one of them, and it's spelled incorrectly, neuromuscular blocking agents. Of course, N-E-U-R-O, neuromuscular blocking agents some of them are listed here for you. They almost all have that C-U-R in the name, like atracurium, vecuronium. Okay, those words with C-U-R come from the word curare, which is an agent that paralyzes muscles. Okay, so these medications are very serious effect on the patient. When they are given to a patient, you will paralyze the patient. Okay, when you paralyze a person, it means even their muscles of respiration are paralyzed and they won't be able to breathe. Okay, so we use these a couple times with these ventilated patients. One, I've seen this with a rapid sequence intubation in the emergency room. If a patient is in immediate need of being intubated and the providers cannot even do not want to encounter any resistance to this ET tube being placed, then they will give them a neuromuscular blocking agent. And that will paralyze them and they can't breathe. But that will facilitate placement of the ET tube. And then they'll be connected to a mechanical ventilator and that will assist their breathing. So another time we'll use neuromuscular blocking agents are for patients who are ventilated and they are agitated. And we can't control them. And also they are doing this thing called bucking the vent. I wish I could show you in real life, but there's this awkward movement of their chest, you know, as we're trying to deliver ventilation under positive pressure, they're fighting it. And we just need them to stop fighting it and to relax so that we can ventilate them. That's when we'll use our neuromuscular blocking agents. And there's a lot more to know in terms of assessing our patients who are under the effects of a neuromuscular blocking agent, but I'm not going to go into that higher level of critical care. But I want you to understand that we do use that for our patients who are bucking the vent to relax their muscles so that we can ventilate them and keep them breathing adequately. Of course, all patients in the hospital, including those that are in the ICU, will be on medication to prevent the development of stress ulcers. And we realize that stress ulcers are GI bleeds that can develop when our patients are in the hospital. There are even at a higher risk of developing GI bleeds or stress ulcers when they're in the ICU. We have studies that indicate that there's a much higher risk of developing stress ulcers when you're in the ICU. So certainly we would want to make sure our patient is also taking something like a Pepcid or Prevacid. When there is a lack of synchrony between the patient and the ventilator, like they're bucking the vent, we just cannot get this breathing done in a synchronous manner. We need to provide analgesia and sedation for the clients. We decrease the client's anxiety and pain. This is a concept that you must recognize, and that's what they're trying to find out if you understand. So do make sure you understand that concept, okay? And just going back a minute about well, actually it's about this. Clients receiving mechanical ventilation may require sedation or paralytic agents, the neuromuscular blocking agents, to prevent competition between the extrinsic and intrinsic breathing. Okay, that means the ventilator and the patient's own breathing, and the resulting effects of hyperventilation. Okay, so if that happens when there's not synchrony involved, the patient begins to hyperventilate, and it's a disaster. Okay. We need to address now the complications of artificial airways, and there are many. Let's start at the top with ventilator-associated pneumonia. It is clinically defined pneumonia associated with a ventilator, with the pneumonia occurring 48 hours or more after the patient is placed on a ventilator, or within 48 hours following extubation. Ventilator-associated pneumonia occurs in approximately 10 to 25% of patients who are undergoing mechanical ventilation. Preventing pneumonia of any variety is a laudable goal, but there are some reasons to be particularly concerned about the impact of pneumonia associated with ventilator use. Ventilator-associated pneumonia is the leading cause of death among hospital-acquired infections, exceeding the rate of death due to central line infections, severe sepsis, and respiratory tract infections in the non-intubated patient. Hospital mortality rates of ventilated patients who develop VAP is 46%, compared to 32% for ventilated patients who do not develop VAP. Now, endotracheal intubation and mechanical ventilation carry risks of tracheal damage and trauma to the lungs. So there is a risk of airway injury, also the risk of developing sinusitis, and an increased need for sedatives or paralytics. Okay. It's frustrating for the patient as well as the nurse when it comes to communication with our patients who are intubated. So altered communication is a complication. Despite our best efforts, it's frequently not doable. They have a decreased ability to perform activities of daily living, so certainly the nurse is responsible for all of the patient's activities of daily living when they're on a mechanical ventilator. Barotrauma is a well-recognized complication of mechanical ventilation. Although most frequently encountered in patients with ARDS, it can occur in any patient receiving mechanical ventilation. High tidal volume ventilation produces the alveolar disruption that triggers the chain of events. Use surgical aseptic technique when suctioning these patients. Monitor their temperature every 4 hours. Monitor their secretions, including documenting the color, the odor, the amount, the consistency. Pseudomonas has a particular odor. It's very characteristic. And we have a lot of Pseudomonas ventilator-associated pneumonia that develops. All of those things should be documented. Barotrauma is lung expansion injury. Barotrauma is used to describe the manifestations of extra-alveolar air during mechanical ventilation. The lung injury associated with barotrauma is mediated by increased alveolar pressures. Okay, the clinical presentation can vary, ranging from absent symptoms with subtle X-ray findings of pulmonary interstitial emphysema to respiratory distress or cardiac arrest due to a large tension pneumothorax. Now, maybe you need to review as well your content related to pneumothoraxes and the difference between a pneumothorax and a tension pneumothorax. Both of these conditions can result as a consequence of a patient receiving mechanical ventilation. Okay. Nursing care is quite extensive for the mechanically ventilated patient. Yes, you might do a thorough respiratory assessment. You need to monitor for complications. You need to monitor ventilator settings and alarms. You need to maintain appropriate cuff pressures. Develop plans for communication with your patient. Administer medications. Suction appropriately. Wean the patient, be involved in the weaning process, and monitor the patient's respiratory rate, level of oxygenation, and signs and symptoms of fatigue during the weaning process. I threw this last picture in here because I wanted to show it to you. And the answer is on the slide itself, but look at these lungs. There you see some patchy infiltrates in the lung. There, that white patchy stuff. It should be dark there. And this is just terrible, especially looking on the right side of the slide or the patient's left lobes. It's full of a liquid. And if you follow very closely, you can actually see a tube going down the esophagus. Well, I'm not sure that's the esophagus, no. In fact, that tube comes down the trachea into the left bronchus and ends up in the left lobe. And you know what? It was supposed to go into the esophagus, into the stomach. It was an NG tube. So now this person delivered tube feeding through the NG tube into the lungs. So that's why we always say how important it is to confirm placement and by X-ray before you deliver tube feeding. Okay? We need to make sure that those tubes that we place are in the proper placement. And so, of course, this patient, more than likely, it was a fatal outcome as a result of this mistake here. So it's something to keep in mind as well.